Hi, Betty.
Hi, Abhishek.
Sorry for this interruption, but you're just in the middle of presentation.
Yeah, that's absolutely fine.
We have many colleagues now, about 550 Egyptian doctors with us, and they are eager to hear your discussion with us. Can we start with questions from Dr. Hani Didi? And Professor Hani Didi is one of head of the units in Qasr Al Aini Hospital, and he wants to ask you a few questions.
Sure, no, that's all.
Welcome, Professor. We are happy to speak to you and share knowledge through our first annual conference of Ganna Hospital. Now, my first question is, what is the new place of IUI according to your publication in British Journal or American Journal?
He's asking about, is there still a place for IUI in the world of assisted reproduction? You have a famous paper on IUI published in BMJ, and another one published in Fast Study in American Journal. So we would like to hear about your opinion. Is there a place for IUI still, or we should go for IVF immediately?
Straight away. Okay. That's a very, very good question. So before I answer your question with a yes or a no, I think it's worth looking at the evidence base underpinning IUI. Yeah. Okay. The first thing is IUI means different things to different people. And if we look at IUI in an unstimulated cycle, which is natural cycle IUI, I think the evidence is reasonably clear on that, because on the one hand there was our trial, which is the Scottish Unexplained Infertility Trial, published in 2008, which showed that unstimulated IUI did not offer a significant advantage compared to no treatment at all in couples with unexplained fertility. At the same time, there is evidence from other sources, and these are trials comparing stimulated with unstimulated IUI, and the major trial there is the David Jusek trial. And the Cochrane review on IUI concludes that stimulated IUI doubles the chances of pregnancy compared to unstimulated IUI. So if unstimulated IUI is worse than stimulated IUI and no better than no treatment, I think we can reject it as a treatment option. Now coming to superovulation IUI, and the superovulation can either be with clomiphene or with gonadotrophins. I think you mentioned the FAST trial, which seemed to suggest that in couples who'd already been treated with clomiphene IUI, another bout of treatment with gonadotrophins and IUI in women who are already ovulating did not offer an advantage compared to IVF. It's worth throwing in at this point that there is one trial, this is the Stewards et al. Trial from the Netherlands, which compared stimulated IUI with no treatment and showed that there was no difference between the two. But it was one trial. I don't know if you're aware, but earlier this year, in 2015, there was months to a year, as compared to IVF with single embryo transfer. And it certainly seems to be better than modified natural cycle IVF. Interestingly, this paper was accompanied by an economic analysis which has yet to be published, although the abstract was presented at London ESHRE 2012, and the first author was Tijon Confat, I think. It is TJON-KON-FAT, and the last author is Madelon Van Berry, who you know, Ishan. And in both the papers, the last author is Madeline, and it's interesting that in the health economic analysis, which only looked at hospital costs, didn't look at societal costs, and superovulation IUI seemed to offer a marginal advantage compared to IVF and single embryo transfer. transfer. So this kind of blows the thinking wide open again, and I think this is where you need to individualize according to your context, and contexts vary widely in different parts of the world. What you will no doubt quote is the NICE guideline, which seems to suggest that in unexplained subfertility, the first option is expectant management. Thereafter, in prolonged, unresolved, unexplained infertility, people should go straight to IVF. But if you read the evidence to guidance text within the guideline, which most people don't read because it's really boring, what you realize is the thinking behind that decision. And the decision is made not because superovulation IUI is ineffective. It is made because in the UK context, where health authorities have only one pot of money and a small pot of money at that, they preferred, on the balance of the evidence, to put the money towards IVF rather than into IUI or shared between IVF and IUI. The reason for that is based on a paper by Pashian et al., P-A-S-H-A-N, Pashian et al., 2006, published from Cambridge, in which the authors modeled the health economic benefits of proceeding through superovulation IUI and then IVF, or going straight to IVF. And what they took into account was the excess costs of treating those who did not get pregnant through superovulation IUI and ultimately needed IVF. And that seemed to suggest that going straight to IVF could be a more cost-effective option. So that was taken into account by NICE, and the other thing that NICE considered was with superovulation IUI, keep in mind that these are women who are already ovulating. So if you want to give them a good going superovulation, you have to be prepared for multiple pregnancies. In the environment in which we have a zero tolerance to multiple pregnancies. Therefore, that didn't seem an appropriate option in a climate where access to an IVF lab isn't difficult at all. So those are the reasons why we felt in the UK that going straight to IVF might be a reasonable option, but certainly the new paper from Prof et al. Held in the context of pre-existing evidence seems to suggest that stimulated IUI does have a place. So the answer to your first question is yes.
Okay. So about NICE guidelines, do you recommend, does it recommend performing AMH, anti-Mullerian hormone, as a routine before any IVF cycle? Anti-Mullerian hormone is now getting more and more widely used or more popular, so is it recommended by your department and by NICE guidelines to do it as a routine?
The answer is no. And let me break that question into two. Your question now was the IVF couples, but many people ask whether it's worth doing it for all infertile couples. The answer to the question whether AMH should be done routinely in all infertile couples is no. The reason for that is in all the studies which have examined AMH, the outcome has always been response to gonadotrophins in an IVF treatment. So therefore, what it is good as a test is in identifying the magnitude of response to gonadotrophins. If you think about what the gold standard is against which AMH is compared in IVF treatment, the gold standard is actually IVF treatment itself. So it cannot be better than IVF in predicting chances of pregnancy or live birth. Having said that, there are circumstances where the decision to progress to IVF or not might be based on a reasonable expectation of pregnancy. So for example, if you have a woman in whom the antral follicle count is very close to zero, age is 43, 44, 45, and an anti-malarial hormone test shows almost undetectable AMH levels, then the interpretation of that is not necessarily that that person should not have IVF, but the chances of getting eggs in an IVF cycle are quite low, and that information should be taken into account when deciding to go for IVF. but I don't think it is right to use it as a test to withhold access to IVF treatment, because scientifically, as I said earlier, the test that is better than this test is IVF itself as a test. Okay?
Okay. So, Dr. Hani, could you please go to the second and third question?
Yeah. Next question is, should hysteroscopy be done as a routine before any IVF cycle?
Hysteroscopy before IVF. Should it be routine? And
No.
actually, in our country, it seems to be a rising concept to do it as routine before any IVF cycle. So, could you please elaborate on this question?
This time I'll start with the answer, which is an emphatic no. And the reason for the no is based, first of all, on the relative lack of evidence showing that removal of an intrauterine polyp significantly improves chances of an IVF pregnancy, and that's not because it's not plausible, it's simply because those data are not there. But nevertheless, I suspect if you do find an intrauterine lesion, most people would want quite naturally to remove it before going on for IVF, and I don't think you would argue with that, because sometimes when something is so evident, you don't necessarily feel that you're in a position of equipoise to do a trial. However, the question wasn't that. The question was routine hysteroscopy in everybody, and in order to answer that, I think the best trial to refer to is the L2P trophy trial. And I don't know if it's been published yet, but it was certainly presented as an abstract. And it shows very clearly that a multi-center randomized trial of pre-IVF outpatient hysteroscopy does not give better chances of success than no intervention in women with recurrent IVF failure. So logically, if it doesn't work in women with IVF failure, I don't think there's any biological plausibility why it should work in any woman coming for IVF.
Okay. Could you, Dr. Fouad, could you please go ahead for our fourth question, please? Dr. Fouad is a consultant with us in Ganna Hospital, and he's going to ask you the fourth question.
Okay, thank you.
What is the interstitial myoma? Before IVF.
He's asking about the role. What you do if you find an interstitial myoma in a patient going to an IVF cycle. Are you going to do myomectomy for an interstitial myoma, moderate size, 2 to 3 centimeter or 4 centimeter even in diameter, or to just go ahead, not encroaching on the cavity, documented by flow hysterography? So what is the role, or what is your experience with this? Are you going to do myomectomy for interstitial myoma or not?
Okay. For this, as you well know, Hisham, there are no randomized trials to guide us. The best evidence that you can find comes from the systematic review of observational data by Elizabeth Pritz. So it's PRITTS 2007, Infertility Sterility. And it's a very good systematic review. The only weakness is there are no trials. So based on observational data, what you get is actually quite an interesting finding. There is no evidence of reduced pregnancy rates if you have an interstitial myoma not affecting the cavity. But there is evidence of reduced live birth rates. Now, clearly observational data are not free from bias, so you can read into it what you will. But nevertheless, I think this is where you have to balance the potential chances of having a slightly increased live birth rate, so less pregnancy loss, fewer complications in pregnancy, versus the morbidity that a myomectomy involves. And I'm not sure that you find a lot of people who will be prepared to put their patient through a quite a bloody and invasive procedure simply on the off chance that it may improve chances of pregnancy, but recognizing that it actually might seriously impact on chances of pregnancy if you, for example, you need to open up the cavity of the uterus, leave a scar on the cavity, and secondly, the morbidity of that procedure and indeed the cost. So the fibroid size that you mentioned does not seem as though it's one that's particularly going to jeopardize pregnancy, put it this way. So I don't have any evidence to guide me here, but thinking through things too logically and taking into account harm versus benefit, I personally would not rush into a myomectomy for these women. If there was a trial that needed to be done, I think this is one, I would certainly be prepared to randomize my patient in a trial.
Okay, Betty, my last question. Do you accept our invitation to come physically to Egypt next year in our conference, in our second conference? Physically, not through teleconference?
If my schedule allows, then I would love to, but it's a long time away.
We love to. So,
okay, but it's a great pleasure speaking to you.
Thank you. All audience here, thank you for your valuable time. Thank you.
I'll send you the papers I spoke about so people can have access to them.
Thank you. Bye-bye.
Okay, bye-bye.